At the age of 40, Mary was referred for psychiatric evaluation. Mary stated on several occasions that her 9-year-old daughter, Sarah, had been placed in the custody of Child Protective Services and replaced by an imposter. Mary also reported that she had given birth to twins, but that the hospital record only documented the birth of Sarah. On occasion, she had shown up at her daughter's school, refusing to pick her up, screaming, "Give me my real daughter. I know what you've done." Despite reassurance from multiple healthcare providers and relatives, Mary continued to express concern that her daughter was not, in fact, her own. She also described several episodes in which her daughter was whisked away before she could talk to her while going about her daily business. For example, Mary related that a car driven by an unknown person, with Sarah in the passenger seat, passed her while she was running errands but sped away once Mary noticed. Following this evaluation, Capgras Syndrome was diagnosed. Mary was having a delusion. Attempts to redirect or help her gain insight were in vain. Given the patient's suspiciousness regarding her daughter's true identity, social services questioned Mary's ability to parent effectively. Mary was prescribed risperidone, used to treat schizophrenia, bipolar disorder, or irritability associated with autistic disorder. Mary responded poorly, and her delusion persisted. Her medication was increased also with poor response. She was taking her medication as prescribed. After 2 months of regular follow-ups and medication management, she continued to display poor insight into her illness. She refused to entertain the possibility Sarah was truly hers, or the possibility that her thought processes were distorted. At that time, the Department of Social Services sought guardianship of her daughter until Mary could be deemed fit to parent. Following the hearing, her daughter was placed into the custody of the Department of Social Services. In response, her daughter replied, "I love my mother except for when she doesn't believe I'm me." During visitations supervised by social services, Mary refused to talk with her daughter, maintaining that she was not Sarah and that the real Sarah had been hidden away from her. Mary's mental illness, Capgras Syndrome, is a rare condition, occurring in roughly 0.12% of the general population and 1.3% of those with existing mental illnesses, such as schizophrenia. When French psychiatrist Dr. Joseph Capgras discovered this condition, he called it l'illusion des socis, which can be translated literally as the illusion of doppelganger. The syndrome was initially considered a purely psychiatric disorder. The delusion of a double was seen as a symptom of schizophrenia and purely a female disorder, often noted as a symptom of hysteria. It wasn't until the 1980s that attention turned to organic brain lesions originally thought to be essentially unrelated or coincidental. Today, the Capgras syndrome is understood as a neurological disorder, resulting from damage to the brain by, among other issues, injury, lesions, or dementia. In a 1990 paper published in the British Journal of Psychiatry, psychologists Hayden Ellis and Andy Young hypothesized that patients with Capgras delusion may have a condition which allows them to recognize faces, but they may have damage to the system which causes the automatic emotional response to familiar faces. This might lead to recognizing someone while feeling something was not quite right about them. In 1997, Ellis and his colleagues published a study of 5 patients with Capgras delusion, all diagnosed with schizophrenia, and confirmed that although they could recognize the faces, they did not show the normal automatic emotional response. The same low level of involuntary response was shown in the presence of strangers. Young in 2008 has theorized that this means that patients with the disease experience a loss of familiarity, not a lack of it. Further evidence for this explanation comes from other studies measuring galvanic skin responses, or GSR, to faces. GSR measures the skin's electrical changes in response to sweat gland activity in the fingers and palms. It measures involuntary bodily response. A patient with Capgras delusion showed reduced GSRs to faces in spite of normal face recognition. This means the person recognizes the face but doesn't have a reaction. William Herstein and Vilayanar S. Ramachandran reported similar findings in a paper published on a single case of a patient with Capgras delusion after brain injury. The patient could feel emotions and recognize faces, but could not feel appropriate emotions when seeing familiar faces. Ramachandran hypothesizes the origin of Capgras syndrome is a disconnection between the temporal cortex, where faces are usually recognized, and the limbic system involved in emotions. More specifically, he emphasizes the disconnection between the amygdala and the inferotemporal cortex. In 2010, Herstein revised this theory to explain why a person with Capgras syndrome would have the particular reaction of not recognizing a familiar person. Herstein explained the theory as being a more specific version of the earlier position he took in the 1997 article with V.S. Ramachandran. Ramachandran suggests a relationship between the Capgras syndrome and a more general difficulty in long-term memory because of the crucial role emotion plays in creating memories. Since the patient could not put together memories and feelings, he believed objects in a photograph were new, even though they should have caused feelings. Others, like Marin and Silberfarb, have also proposed links between the Capgras syndrome and deficits in aspects of memory. They suggest that an important and familiar person, the usual subject of the delusion, has many layers of visual, auditory, tactile, and memories associated with them, so the Capgras delusion can be understood as a failure of object constancy. Object constancy means maintaining a positive attachment to someone, despite their absence or when they are frustrating. It's about understanding that a person still exists and has positive attributes, even when they are not present or not fulfilling a need. Capgras delusion is not just the impairment of the automatic emotional arousal response, as the same pattern has been reported in patients showing no signs of delusions. Ellis suggested that a second factor of an impairment in reasoning, although no specific impairment has been found to explain all cases. Many have argued for the inclusion of the patient's perspective to better understand what causes the creation and maintenance of delusional beliefs. Capgras syndrome has also been linked to another delusional misidentification syndrome in which a person believes a location has been duplicated or relocated, known as reduplicative paramnesia. Since these two syndromes are highly associated, it has been proposed that they affect similar areas of the brain and therefore have similar neurological implications. Reduplicative paramnesia is understood to affect the frontal lobe. Therefore, it is believed Capgras syndrome is also associated with the frontal lobe. Even if the damage is not directly to the frontal lobe, an interruption of signals between other lobes and the frontal lobe could result in Capgras syndrome. Some authors have highlighted cannabis consumption as a trigger for Capgras syndrome. The symptoms of Capgras include a genuine belief that a close relative, friend, or significant other has been replaced by an imposter. A sudden change of behavior when dealing with that person. Refusing to talk to or talk in the presence of the believed imposter. Feeling fear or anxiety in the presence of the believed imposter. Acting aggressively towards the believed imposter. This may include verbal outbursts, threats of violence, or attempting to physically attack them. Acting aggressively towards other loved ones who do not believe there is an imposter. Feelings of agitation, anger, upset, or confusion. Feelings of paranoia or a lack of trust towards the believed imposter and/or other close family members and friends. Refusing to accept any evidence that shows the person is not an imposter. Becoming focused or fixated on exposing the imposter. Treatment of Capgras delusion has not been well studied, so there is not an evidence-based approach. Typically, treatment of delusional disorders is difficult due to poor patient insight and little research. Treatment is generally therapy, often with antipsychotic medication. Capgras delusion is often a symptom rather than a syndrome itself, so treatment may focus on the underlying condition. Hospitalization may be needed if the patient is engaging in self-harm or violence. Caring for a patient with Capgras can cause untold mental and physical illness for the caregiver. If you know someone with Capgras, try to remember to accept the situation. Trying to prove you aren't or someone else isn't an imposter may increase tension between you and your family member. Trying to convince them that they're wrong can lead to anger and aggression. Announce yourself. Capgras syndrome doesn't seem to affect voice recognition. Saying hello before you appear in your family member's sight may reduce the chance they'll react. Find a short-term substitute. Asking someone to step in as primary caregiver isn't a permanent solution, but taking a break may help ease tension between you and your family member. Sadly, this condition is not curable and it won't go away. Antipsychotic medication and treatment like counseling often ease symptoms. So, what are your thoughts? Do you know anyone who has Capgras syndrome? Please leave a comment below. Thank you for watching.